next session is going to be hand and upper extremity. I do want to thank again Baptist Health International for putting this together. I think it was a really great opportunity for people to get together and talk. So again, thanks to the International Department, thanks to Roger, everybody, you know, Nicola, Raul. So first up is going to be Roy Cardoso. He's going to talk about forearm fractures. I am honored to have him as my co-conspirator on this meeting.
So this morning was filled with really innovative talks from the foot and ankle and the joints guys talking about robots and MIS and all that other sexy stuff. So it's time to recalibrate our expectations, and we're going to talk about something a lot more mundane, but I think important. You know, when we talk about forearm fractures, I think back to, you know, as a resident, these were some of the first cases I was involved in, right? So pretty straightforward. You plate some bones, you go home, and you feel good like an orthopedic surgeon. But I think there's some subtlety to forearm fractures that makes them interesting. So hopefully I can highlight some of that. So here's a case, fairly standard. This is like a Monteja type fracture. You see here, and this is kindly shared by one of my trauma colleagues in town who's a very good surgeon. And so they plated it like this. Does anyone see any like particular problems with this? It looks like the bones are pretty lined up. It looks like the fracture is reasonably reduced. But this is what happens. You get a dislocation of the radial head, and we'll talk about why there's a problem with how that fracture was fixed. So, you know, what's interesting about forearm anatomy is really the relationship between the osseous anatomy and the ligamentous structures. As hand surgeons, unlike our trauma colleagues or our joint colleagues, we like to mess around with the things in between the bones, those soft, mushy parts. And that's what makes forearm fractures and forearm anatomy interesting. And so the forearm helps to maximize rotation and power while maintaining stability proximally and distally at the elbow and the wrist. So the way the forearm can do this partly is because of the shape of the bones. We all know about the radial bow, but actually the ulnar bow is equally as important. And then we have these ligaments, the interosseous ligament, the TFCC, that help to tether these two bones together. So again, they're long bones, but they're not straight bones. And we all know about the bow of the radius. What is, I think, underappreciated are the various bows of the ulna. The ulna has the the proximal ulnar dorsal angle, which is critical, and the reason that fracture failed was a little bit of failure to recognize that you're putting straight plate on a curved bone, and so it was not reduced anatomically. And so there have been various iterations of ulnar plates, but what's critical is that you have fixation or recognition of the anatomy or fixation that matches that. We're going to also talk about the forearm as a joint. So if you think about the forearm as having two fixed lengths, the radius and the ulna that are fixed, you have joints both proximally and distally. You have this sort of parallelogram is the effect, and they rotate as one functional unit. So it's really a joint, not two bones. And the radius, as we all know, rotates on this fixed ulna. And so talking about these, taking a deeper look at the ligaments between these two bones. So you have this central band, and then you have a proximal oblique cord and a distal oblique cord that help to fix this. And what's interesting about the interosseous ligament is that both in the anterior and posterior views, and in pronation and supination, it's an isometric ligament. So you see here that, and this angle has been, this is a 21-degree angle, but you see that there's an isometric ligament in all ranges of motion. So taking a closer look again, you know, it's the purpose of the ligament is to load transfer. So we have the forearm transmitting load and the ligament helps to distribute that load evenly between the proximal radius and the proximal ulna. You have this balance that's created. So this 100% load gets evenly distributed between the two bones. And so when we do have an injury, so you have a radial head fracture and you have an injury to the interosseous like in an Essex-Lopresti lesion, you have this migration and you have this disruption of the load. And so now the load of the interosseous ligament is greater than the axial load, and you have failure. You get this migration that we all know about. Interestingly, restoring the length, the ligaments prevent, these proximal and distal ligaments prevent over-lengthening of the radius, which is a benefit. And so we're thinking more about the ligament and the relationship of these two bones, the soft tissues, rather than just thinking about the bones themselves. This is true for ulnar impaction syndrome, a bunch of other things where we always focus on the bone, shortening the bone, when maybe the problem is not the bone, but it's in fact the ligament and ligament tension. I'm going to switch gears briefly to Galeazzi fractures. You all basically know what this is. It's an injury to the distal radial ulnar joint along with a distal radial 1/3 fracture, the counterpoint of the Montesia fracture. And it was first actually described by Sir Astley Cooper. He described this in 1822, but it wasn't until 1934 that the eponym Galeazzi was presented. And Riccardo Galeazzi, he's actually not the most famous Galeazzi. There's another Galeazzi who was actually he was the doctor for the Pope, and he left the Vatican in disgrace because he was responsible for the embalming of Pope Pius. And so the typical embalming method is to drain blood from the body, et cetera, and he decided that he has a new way, and he wanted to innovate that with the Pope, and it involved keeping it at room temperature, not draining the body. And he filled this plastic bag with these herbs and spices. He's like the Colonel Sanders of embalming, apparently. And the body apparently decayed in front of everybody. It rotted, essentially. And apparently there were these Swiss guards that fainted from the stench, and it was a big mess. So if you look up Galeazzi, that he is the most famous Galeazzi. So this Dr. Galeazzi is from Milan, and he published on his experience with these 18 fractures and described the mechanism, incidence, and management of these Galeazzi fractures. And its more defined treatment was described by Houston later. Mechanism, it's a fallen and outstretched hand. The rotation of the limb as it interacts with the ground or whatever object determines the mechanism of the injury. There are 7% of all forearm fractures. A fourth radial shaft fracture is a true Galeazzi fracture. There's a bimodal distribution. As many things in upper extremity trauma, there's high energy trauma versus low energy falls. Reddick and Raskin basically described two types based on how far the fracture is from the distal radial ulnar joint, and the magic number is 7.5 centimeters. So if it is close to the distal radial ulnar joint, understandably it's associated with significantly more instability than if it's more than 7.5 centimeters. Other concerns, anterior interosseous nerve palsies. And then the other most interesting thing about these Galeazzi fractures is, what do you do with a distal radial ulnar joint? So are you splinting them? Are you pinning them? Are you exploring them? How do you decide? And so there's so many algorithms out there, but basically if you can reduce them and they're stable, then you splint them in supination for 6 weeks. If they're unstable, you have the option of pinning them or looking to repair the TFCC. So reduction in pin versus screws versus opening the TFCC and actually fixing it. And so this is a very, very busy slide, but essentially going through that protocol, and if it's reduced and stable, you leave it alone. If it's unstable but reducible, then you have to decide if you're going to pin the two bones together or if you're going to go in and repair the TFCC. And obviously if it's irreducible, you have to explore the ligament and then decide to either fix it or pin it. So that's basically it. The forearm is placed in supination. You have to watch out for compartment syndrome and anterior interosseous nerve palsy. I take the pins out at about 6 weeks, and then we recheck for alignment. So that is it. Thank you very much.
All right, thanks again to Dr. Roy Cardoso. Before we get our next speaker up, I do want to, again, thank the international department. Apparently we have 24 people logged in internationally, so that's really neat. It's a success, so it's great. Our next speaker is Dr. Rafael Diaz-Garcia, who's going to be talking about basically nerve and tendon transfers. So welcome.
And thank you all. And as we've been talking all about the joint replacements, I had a little bit of jealousy that we don't have any robots yet for anything that I do. But I joined Baptist about a year ago, and like most things Roy was talking about, we take care a little bit about everything, but I have a personal interest and passion for nerve injuries. So, nerve is something that I think we all interact with. A lot of us are scared of. We try to make these planes between the radius and the vessels and the nerves and try and do whatever we can to get down to the bone without ever seeing the nerve because we're worried what might happen if we injure it, because ultimately when there's an injury, the recovery is never 100%. So I'm hoping to really just do a brief overview. Any one of these topics we could literally spend an hour, but discuss peripheral nerve injuries and the evaluation in them, what the algorithm is with chronic injuries, on what to choose, and ultimately show some cases that I've done in the last year here to talk about kind of my decision making and why. So, nerve injuries are mostly common in working age population. So these are young laborers, whether it be in motorcycle accidents, whether it be industrial accidents. Most of these people need to get back to work and have numerous years of productivity in them. And because this is such a hardworking population in general, the socioeconomic costs of an injury is significant. In a perfect world, if you have a laceration, a clear laceration or injury, getting to it early and repairing it primarily is still the standard of care and really the best option for recovery depending on the location. But sometimes, based on either the history of the patient or the nature of the injury, you can't get primary repair. And so deciding whether or not you're going to do something for the gap, whether it be grafting or allografting, or some type of nerve transfer, or do they present in a later fashion, then limiting the options you have. All of us during our med school and early training days talked about nerve injuries and Wallerian degeneration. Ultimately, the idea that when you injure a nerve, in the first 3 days, you start seeing loss of the axons downstream, and you have this influx in the first week of macrophages that come in and essentially take away everything except for the microtubules, and you need to get new growth from the proximal cell body to go down to the terminal end plates. For closed injuries, really timing dictates what you're going to do at that time. So when do they present to you? Do they present at the time of injury? I really just want to get a good exam if it happened the day of so that I can follow it. Does it get worse? Does it get better? And then really following those patients closely, usually at 6 to 8 week intervals, getting a good understanding of which muscles innervate in order so that I can keep track of their reinnervation. And if they either don't progress as I expect them to, or stop altogether, then getting nerve conduction studies to see, are they progressing? Do I have evidence electrophysiologically of reinnervation? And if not, then really talking about intervention. And that surgical intervention, at least in terms of some type of nerve, recovery, directly to the nerve transfer, nerve grafting, is usually going to be somewhere in the 3 to 9 month range. So somebody who's a year and a half out from injury, I'm not even really thinking about their nerve unless they're talking about pain. I'm thinking about tendon transfers and trying to reconstruct their overall ability. But if you get them early enough, then you can start discussing whether or not nerve transfers, nerve grafts make sense and can potentially give them a better outcome. Nerve injuries are, mostly from mechanical trauma, but I've seen them from toxins, I've seen them from burns, I've seen them from external beam radiation for metastases treated in the humerus, as one of the patients I'll show. And obviously the type of injury is important to have in the history because it gives you an idea of the zone of injury you're dealing with and whether or not that is a hostile bed to try and operate in. So somebody who has a sharp laceration, then they have minimal soft tissue injury, you're more likely to be able to do something locally. Somebody who has a gunshot wound or had a bad burn that it's multiple segments of that extremity, well then I really want to avoid that altogether unless I'm going to do some type of soft tissue reconstruction as well. And thinking more of things like distal nerve transfers. So, tendon transfers, the idea of a tendon transfer is that you are taking a functional muscle that does a different function, has done it his whole life, and you're going to use that function to reconstruct something that they're lacking. So the key principles that go back to Dick Smith at Mass General, 40 years ago, is that you do one transfer for one tendon for one function. You want it to have a straight line of pull. If you have to make it, take a turn somewhere, you're going to lose some of that strength and you're going to lose some of the efficacy of that transfer. You need to have sufficient excursion. The same idea that you can't take your pronator quadratus and try to make that a digital extender because obviously the pronator quadratus doesn't have much excursion. And you need strength. So a weak muscle isn't going to be stronger once you do a tendon transfer. Usually you actually lose 1 BMC level when you do that transfer. So if you're using a 3 in somebody who had a multiple nerve injury extremity, you can't use that muscle to do a tendon transfer because you're going to weaken it. You're no longer going to have even anti-gravity function. And you need to have an intact soft tissue envelope. So for somebody who comes in with a long-standing injury but a lot of scarring, maybe they had skin grafting, if you don't have a good soft tissue bed to have that tendon transfer go through, you may need to stage that. You may need to do a free flap or bring some type of soft tissue to give a hospitable bed for your tendon transfer to be able to pass through later on. The best candidates are going to be patients who have chronic injuries. That's when you've kind of given up the chance of their reinnervation, and usually you use a cutoff of about 18, but usually I'd like to think people may see some recovery up to 2 years, so I'll wait if I can. People who have failed nerve reconstructions before, people who have limited nerve options, and really you start thinking about combinations of arthrodeses with tendon transfers to try and improve their function. Common applications, so people with radial nerve palsies, commonly from a humerus fracture, median nerve palsies, classically from long-standing carpal tunnel, but anything that caused a median nerve injury, you may want to reconstruct their thumb opposition to put their thumb into better space. Ulnar nerve palsies, the intrinsic function, particularly with clawing, can really limit their ability to even grasp a cup. So being able to put their hand into better posture will make a difference in how they use that hand. And then for our foot and ankle colleagues, people with tibial, anterior palsies from a peroneal nerve palsy can ultimately get TP transfer to stabilize the foot. The advantages are these are fairly straightforward operations. Patients recover much faster, so you may have to splint them for a few weeks, but then you get them moving with therapy. And then usually I tell patients that by 6 weeks I don't really have any restrictions, and by 8 weeks they should be kind of plateaued. They may still see some gains, but they're back to most functions. The problem is that it's non-physiologic. You're trying to use synergistic transfers, but oftentimes you're kind of using a B choice muscle to do an A choice function. And oftentimes you have one muscle trying to compensate for what would be normally multiple muscles. So for instance, classic FCR transfer to EDC has good excursion, has good strength, but you can't individually extend those fingers because you have one muscle now that contracts and pulls them all together. And then they do have to have access to rehabilitation. So nerve transfers have really popularized over the last 20, 25 years. Susan McKinnon at WashU was kind of like the first person to start pushing it, but goes back to Christophe Oberlin in France talking about Oberlin transfers or FCU motor transfers to get biceps flexion. And the idea there is you have a functional muscle that just is denervated, right? It's early on. You have functional nerves nearby, and by rewiring the circuits there, you can have synergistic motion, and you now don't really need to have that one line of pull, one muscle, because as long as you get about 30% of the normal axonal count to reinnervate that muscle, you actually have normal contraction. So people can get really great results in the right patient population. But you do need to have healthy nerve to try and do the nerve transfer, and you have to get to them early. So that's why I say that 6 to 9 month window is when I'm really kind of making that decision to operate on them, because if they show up a year, year and a half out, you're probably not going to be able to get reinnervation in time, and you kind of are going to waste that nerve transfer. So your best candidates are going to be those acute to subacute injuries, patients with high proximal injuries, because you know that the time to reinnervation is going to be longer than you have access to. Younger patients, they have more neuroplasticity, they're more likely to have regeneration in a timely fashion. And these are some of the common ones, so like the Oberlin transfer for elbow flexion, or the double fascicular that McKinnon has popularized, AIN to the ulnar motor to prevent clawing and give better posture to the hand. And then I mentioned the tibial to peroneal nerve branches, which is, I'll tell you, works in the sense that you can make that muscle contract, but I'll tell you it does not work for patients because it's not a very synergistic transfer, right? So toe flexion and extension of the ankle, dorsiflexion of the ankle, don't ever happen together. And so I've done them in practice in the past, in my previous job, and for your office, you can get them to extend their ankle, and it can look really good on your video, but when you actually try to get them to be able to have improved gait, it doesn't really work. Patients just don't relearn that. And so I think they do much better with tendon transfers for that particular indication. So the advantages, so you're preserving those original muscles, you're just giving them a new source of signaling. It's more physiologic, they have better fine motor control, and it's kind of, I tell patients, it's the home run, right? If you get it to work, they do so much better, but you gotta pick those patients. It's time dependent, so the longer you've waited from the injury, the less likely you're gonna get recovery. It's variable, so versus having over 90% success rate with tendon transfers, you're more now in the 78 to 82%, depending on which transfer you're talking about. Older patients struggle with the cortical relearning. It does require comfort with intraneural dissection, being able to coapt 9-0 sutures between fascicles, and really understanding the interfascicular anatomy of each of the nerves we're using. So this is kind of a framework of when I'm thinking about tendon transfers or nerve transfers. So a younger patient who comes in fairly early after their injury, I know that based on their nerve conduction studies that those muscles still have a lot of fasciculations, which tells me they're very viable. I haven't waited a long time, so I know I can get them reinnervated. And they want to swing for the fences and get the best option, then those are patients that could do well with nerve transfers. Patients who are older, patients who have chronic injuries, patients who may not be somebody who wants to have to do therapy for 8 months to a year. They just want to get back as quickly as possible, and they don't necessarily want to be invested into this long recovery period. They're going to do better with tendon transfers. And then again, time-based, so early injuries, acute, sharp, primary repair. Longer injuries, I'm starting thinking about nerve transfers, and chronic injuries, tendon transfers as the primary option. Young patients do better with nerve transfer outcomes than older patients. Older patients are going to be happier with the predictability of a tendon transfer. Patients who have comorbidities, so diabetes obviously we know is neurotoxic. It impacts our nerve regeneration. Same thing with vascularity, so patients who either smoke or have history of coronary artery disease, you start thinking that maybe they're not going to be the best candidates for nerve transfers. While people who have soft tissue problems, rheumatoid, lupus, they may not do as well with tendon transfers because they may loosen over time. And so let me just go through some cases. These are patients I've taken care of here. This was a 73-year-old female that came in from the Dominican Republic. She was 3 years out from supposedly excision of a benign breast mass. And the surgeon told her that, the mass was on one of the nerves, told her it was the radial nerve. Took out her medial cord. And so she waited horrible pain for over a year. She comes to see me 3 years out, and she had actually recovered function of her ulnar nerve, but still had a high median nerve palsy. On appearance, she had a hand of a benediction. She had some function of her middle finger, probably because we know that there's some cross innervation of the medial FDP from both the ulnar and the median. But she had no sensation in the median nerve distribution and really struggled with lack of AIN, particularly with thumb flexion and index finger flexion. And so I took her ECRL and I used that as a tendon transfer, rerouted to now give her flexion of her FDP of the index and her FPL. I did a side-to-side of her middle finger FDP to the ring to give her a little better excursion. And then because she was insensate, and sensory transfers you can really do years down the line, I took the dorsal sensory branches from those fingers and then rerouted them to the key digital nerves to give her key pinch back with protective sensation. And so here you can see the tendon transfer as well as the sensory nerve transfer. And at 3 months, you can see that now she has flexion, and I saw her at 7 months. She was now getting some protective sensation along the distribution of her ulnar thumb and radial index. This was a patient who had a history of thyroid cancer. She developed a metastasis to her humerus. She was treated with external beam radiation, and she developed a radial nerve palsy. And she comes to see me. She's 4 months out. She has no function of her radial nerve distal to the triceps, except for sensory, where she has about 50% of her contralateral side in the sensory distribution. And so I talked to her about the options. I gave her, she's young. I said, I can give you tendon transfers. You can kind of be back to activities in a couple months, or we can swing for the fences and do a nerve transfer. So she opted for a nerve transfer. And so here you are, again, people oftentimes try and avoid these things. I'm looking for them. Here I'm dissecting out the motor branch, the FCR, going into the muscle, trying to get as much length there. And then the FDS usually actually has two kind of bundles that go into it. So take the more proximal of the two bundles. I stimulate the nerve to make sure that there's another one, that I'm not sacrificing FDS function. And like I said before, you only need 30% of the nerve to maintain normal function. So you can take half and they don't see a deficit. And then go ahead and transfer. I dissect the superficial radial nerve back as my way to find the nerve proximally. I find the ECRB, take my FDS branch, go to ECRB to give wrist extension, and then FCR to PIN to try and give digital extension, where you can actually get independent digital extension with this transfer. I don't know how I can play this. Does anyone know? Great. So this is 5 months out. There's no tendon transfer that allows you to give them extension in one position of their wrist. They get this kind of static position where their wrist is held in neutral, and with tenodesis, they can get a little bit of motion, but to get that full flexion and extension, you can't get. And then I tell them up front, 5 to 6 months to get wrist extension, and about 8 to 10 months to get digital extension. So she's halfway there, but she knew that up front and was okay with that plan. And then case 3, this is a patient I just operated on recently. 26-year-old male, had a history of anterior shoulder dislocation, had plexus was completely out, was left dislocated for almost 8 hours, but posterior cord was still intact. Recovered over the time I was following him, but was starting to get a little bit of AIN function back. And we talked about waiting, potentially doing tendon transfers later. Really wanted to do something to preserve. So I told him, well, there aren't great options when you have 2 nerves that were injured originally. I would much rather have a nerve that was completely normal. But because the AIN doesn't give you that much of a loss, people don't really miss their peroneal quadratus. I offered him a distal AIN transfer. And so I released his cubital tunnel. I transposed his nerve because it was subluxing. I stimulated intraoperatively. I saw the AIN to the peroneal quadratus was contracting, so I knew that it was already reinnervated. I knew that it wasn't normal, but I didn't have any other good options, and I haven't burned any bridges, so I can still do tendon transfers in the future if he doesn't get good function out of it. And thank you very much for your time.
So 2 great talks. Does somebody else want to start with questions? Otherwise, I can share a case. Go ahead.
A quick question on the nerve transfers. I have a patient with a gunshot wound to wrist, and we know that the superficial branch, the ulnar nerve, is gone, and there's the zone effect of the gunshot wound affecting, and the neuroma of the other branch of the ulnar nerve. What would you do for assessing the next move at 3 months?
And motor function's always been fine?
Ulnar nerve? No.
So both motor and sensory are out?
Correct.
Yeah. So at 3 months, I would probably be talking to them. If it's at the wrist, I don't think there's any good options for transfers. I would talk to them about resecting the neuroma. Intraoperatively, once you do a neurolysis, you can dissect out the fascicles and try and do stimulation to see if there's any motor function that's working after neurolysis. I've been surprised by sometimes, somebody comes in with a C5-6 palsy, and I explore them, I release their scalenes, and as soon as I take off all the scar from their plexus and I re-stimulate, now it's contracting. So if I see that after my neurolysis that I'm getting some contraction, then I probably would save those fascicles and then autograft what wasn't working. And I plan for essentially taking their whole sural nerve and doing multiple cable grafts.
Question for Dr. Cardoso. How important in terms of that proximal ulnar bow to get that anatomical with your mantisia fracture? Because that case that you showed, that same thing has happened to me, where I fixed it and then afterwards the proximal radioulnar joint dislocated after surgery.
Yeah,
but it's something that we tend not to focus, well, at least I don't, a lot on in terms of fixing the fracture, in terms of getting back that dorsal bow.
Right, I think it's pretty important. It's pretty common, so it's not just you. I think it's pretty common to misinterpret how bent the ulna is. A lot of the newer implants incorporate the bow quite well. What becomes difficult is if you're planning a fracture out and you see the X-ray and you're like, oh well, this is a mid-shaft fracture. I can use a straight plate and that's what you have available. But inevitably you have to go more proximal than you think, and you have to take into account the bow. So I think it's quite important. What degree does it have to be like equal to the other side? A 30-degree bow, I can't tell you that there's an exact percentage that you have to be close to in order to have a stable proximal radial ulnar joint. But it definitely needs to be considered always.
Yeah, I think that Dr. Cardoso was saying, I think that the anatomic implants have made that a lot easier. I think that before, particularly because you're going from a dorsal approach and you're seeing, 2.5, 3 cortices, and you can't tell the gapping on the volar side. But with an anatomic plate, it kind of gives you another registration point, like, oh, why am I still not lined up with this plate? I shouldn't be bending this plate this much. Maybe I have to get another look and see, am I lateral? Am I actually gapping?
Yeah. And to that point, the surgeon who did that, he went in with that idea that it was a ulna fracture, and he needed a shaft plate. And so some of the sets don't, if you have an olecranon plate, an extended olecranon plate versus a shaft plate, that's something to consider what you have in your operating room when you go in to make sure you have those anatomic plates, because some of the forearm systems don't have them.
The bone has a kind of a triangular cross section. So if you plate either medially or laterally, you avoid that problem, don't you?
Correct. But as you go more proximally, that shape changes a bit. But yes, it is a triangle.
Yes, I find if you plate on either side as opposed to on the subcutaneous border, you avoid the problem.
If you don't go direct posterior.
Yes. Okay.
Question for Dr. Cardoso. I've seen a reference to reconstructing the interosseous membrane. Is that something that's, coming more into the fore?
It is. I've only done it twice, so I can't tell you much about that. So it is becoming much more common. There's actually a system now that Skeledynamics has come out with that actually has a kit that makes it a little bit easier. But yes, it is being thought of much more often and considered more frequently, yes.
Yeah, I think I've done one in 11 years, and at that time was using a tightrope from Arthrex with a combination of tendon graft. But it is difficult to get the right angle and the right tension. It's very humbling.
Do you remember your indications for those?
So for me, it was a case of a radial head fracture that I fixed, and it failed. And in sort of exploring how it failed, I realized that his interosseous ligament was incompetent. But I didn't recognize initially, it didn't present as a typical exoskeletal injury. And the other one I did was a sort of more obvious, heavy, big trauma when we reconstructed the IOL because it was obvious. But in this person that first did a radial head, failed, and then eventually came to the right conclusion that he did in fact have an interosseous ligament weakness. And it's probably seen me a lot more than I've recognized in various patients. There's thoughts that ulnar impaction syndrome as well, because it increases in older ages, is probably due in part to incompetent interosseous ligament. Sir.
I recognize that the correcting the bow and the ulnar was part of the solution for that patient. What about the radial head? Did you feel a need to reconstruct the ligament?
I certainly don't on a regular basis. I think most of the time, if you get the reduction, if you can get the reduction intraoperatively, meaning that it's stable when you leave the OR and you have correctly aligned the ulna, I don't think that's necessary. At least I haven't seen it necessary. I don't know if Rafael has any other thoughts on that.
No, I was going to say that same thing with like Essex-Lopresti injuries. I think there's probably a lot more patients who have Essex-Loprestis that we don't necessarily diagnose. We just see the radial head fracture, and then when we treat it, we're kind of treating the Essex-Lopresti, and as long as their radial head doesn't have a problem, doesn't go into non-union or doesn't displace, then they're fine. It's only when you have to do a revision and you go in and you say, oh, maybe I'll just do a radial head resection, arthroplasty, and then when you go to the DRJ and pull on the radius that you realize that it's translating.
I had a situation with Essex-Lopresti was recognized, but the radial head was, multifragmented. But it extended also to the radial neck. And when the radial head arthroplasty was used, I found myself wishing that I had a modular prosthesis because I could not make up the neck length, even though the correct diameter. And then I started to wonder if I could equalize that situation by doing an ulnar subtraction at the other end, which I figured would be quite difficult to balance. Then I thought about the interosseous membrane, which was the original aspect of the injury. That is still a situation in evolution, however. Just wanted to.
Any other questions? I have a question for Rafael. So do you ever do any stuff with lower extremity, with the nerve stuff? So like I had a patient who had a Achilles repair that I did, and it was noted afterwards that when they had their nerve block that they probably had punctured the nerve proximally. So the patient had no function in their gastroc and dysesthesias on the foot. What is your approach to that kind of case? Have you ever done? They talk about a kind of nerve charging procedure where you take another nerve to kind of stimulate the healing, or do you just wait? Or supercharge, I guess is the correct.
Yeah, it depends on what the injury is. I definitely wouldn't do anything acutely. I think I would give them at least 6 or 8 weeks before I get a nerve conduction study to see, and then I would probably follow them for a couple of months. The issue with a nerve transfer is you're robbing from Peter to pay Paul, and so if their soleus was completely intact and their gastroc was the only thing that was weak, I probably wouldn't offer them a nerve transfer because I don't know that. We know with reconstruction for limbs that we'll take a gastroc, but sometimes both gastrocs for for knee salvage, and it doesn't affect their gait. Now they're not going to be playing sports, but it doesn't affect their gait, and so I'm not going to necessarily weaken their soleus or weaken something else to only get kind of back to where I was. So I mean, I had a patient who came to see me who had what looked most likely like Parsonage Turner, and really only had weakness of the brachialis, which is a weird presentation because usually you see like long thoracic or AIN, and had clear atrophy as brachialis, but had good strength of the biceps. And he came to me to get a nerve transfer. I was like, I don't think I'm going to make you better. And ultimately, like, you have good function. Like, yeah, it's cosmetically not the same, but having a bunch of scars and ending up kind of the same strength isn't doing you any favors.
Thank you.
Great talks. This is for Rafael. When you see a patient and you decide tendon transfer versus nerve transfer, you offer nerve transfer. It's not, the outcome is not as good as you want it to be. Then you use a tendon transfer as an option, as a bailout.
Yeah, I mean, everything, when you're doing nerve surgery, you're kind of thinking 3 steps in advance, and you don't want to burn any bridges. So for instance, the last patient who's recovering AIN but doesn't have any ulnar nerve function, I did tendon transfers for FDP at that time. My AIN's really to try and get some intrinsics back, and I can always come back and do, his ECRL, ECRB were never affected, so I can do a foretail transfer for his fingers to maintain better posture with tendon grafts from palmaris longus, and I can use the EIP for an opponentsplasty if needed.
Following on that, are there any watershed situations where you actually do both? Like you do a neuroraphy at the same time that you do some tendon work? Because it's probably a little too late for one or the other. A little too early, a little too late for just the nerve repair only. And probably on the watershed of time for you to just do outright tendon transfers. Do you ever do both?
Well, I showed a couple of cases where I did do both, one for sensory, one for motor function. But I do try to separate the two because I have all the time in the world for tendon transfers. And so I don't want to, and obviously I'm always robbing from Peter to pay Paul. I'm going to give them some weakness somewhere to provide a new function. And with tendon transfers, unless it's a side-by-side where it doesn't really make a difference, right? They're not going to lose function from it. I don't want, even if they recover, they're still going to have that function, and FDP kind of goes as one muscle belly anyway. I don't want to impede their recovery because of the tendon transfer that I did. So in general, when I'm talking about motor stuff, I'm thinking nerve transfers early or tendon transfers late. Unless it's someone who's really older and doesn't want that recovery, then I might go straight to tendon transfers. But even then, if I had somebody who had a radial nerve palsy from a humeral shaft fracture and didn't want nerve transfers, I would try and kick that can down the road and deal with it later, because I know that they may still see some recovery. I mean, it's not uncommon that we see them bounce back at around a year. The reason I operated on her early was because she had radiation, and I did not feel comfortable that a 40-year-old, even who had been radiated for 30 sessions, was going to see necessarily good nerve recovery from that nerve.
Thank you. I think that's great. I mean, the only thing I would add is if Dr. Galeazzi was truly Colonel Sanders, was that Pope finger looking good? So. All right, I'm going to sit down.